So hello everyone. I'm Stefan Tullius. I'm the editor-in-chief of the Transplantation Journal and Transplant Direct. And I have with me Camille, Kotton, and Atul, Humar, who both chair the fourth International Consensus Guideline meeting on the management of CMV in solid organ transplantation. Just for quick introductions, Dr. Camille Kotton is the clinical director of the Transplant Immunocompromised Host Service at Mass General Hospital in Boston. She's also the secretary of TTS. And Dr. Atul Humar is an infectious disease specialist at the Transplant Center of the University of Toronto in Canada. This is a very interesting, comprehensive document. Previous guidelines on CMV have been in 2008, 13, and 2018, and this most recent event convened in Montreal in 2024. I can highly recommend this document. It's wonderful in its completeness, its way of thoroughly going through all aspects of CMV treatment, and it keeps us up to date. I want to start out with a few questions I have, and I also want to cover the entire CMV aspects that are presented in this document, and I also want to emphasize with a few clinical cases on relevant aspects. By starting out, how did you both, in sharing this meeting, arrive at those guidelines that are published now?
Sure. So thanks for the warm welcome. Atul and I are always happy to talk about CMV. So to develop the guidelines, we developed a committee of roughly 50 international experts who've published on CMV and had a lot of experience in the field. And we divided up into 6 different work groups, and there was a lot of work done before the meeting. We also solicited independent funding from industry partners, and we have about half a dozen industry partners who donated into a fund that was not visible to anybody participating in the meeting other than Atul and myself. So it is supported, but independently supported. And then everybody in different work groups developed guidelines and kind of came together with what they thought would be the best guidelines for all the different areas that we'll talk about. And then at the meeting, they presented what they thought were good guidelines and sort of ramifications and risks and benefits and all of that. And then we actually did a lot of voting at the meeting and a lot of discussion and work groups. And we spent 2.5 days working pretty hard on this, but reached consensus by the end of our time together. And then we wrote it up, and that's the publication. And we're happy to have this available. It is open access, so widely available throughout the world. We were really happy to have many places in the world represented from all kinds of, high income, low income countries, all diverse areas geographically. So the goal was to really have representation throughout the world so that everybody could be using these guidelines for the most common infection after solid organ transplantation.
No, congratulations. A wonderful meeting and a wonderful document. So starting with the basics, what are relevant definitions clinicians should use for CMV infection, disease, prophylaxis, and treatment?
So thank you, Stefan. So we use the definitions that are commonly used in clinical practice, we used in the guidelines, as well as that are commonly used in clinical trials evaluating CMV. So in the solid organ transplant patient, CMV infection means the detection of replicating virus. And the most common would be through detection in the blood by a quantitative NAT assay. So CMV DNA emia is what we refer to as in the guidelines. But you can also detect it in other tissues and using other methods such as culture or antigenemia. And that should be distinguished from latent infection, which implies non-active replication. And then CMV disease is the presence of infection plus symptoms. And typically this would be a viral syndrome as the most common manifestation, but then also any form of tissue invasive disease could occur as well.
So in your document, which is so comprehensive, you really cover the entire spectrum of relevant aspects in CMV: prevention, diagnostics, immunology, treatments, and then finally pediatrics. Starting out with prevention, what are updates in this area?
Yeah, so one of the exciting updates is that we actually have a new drug for prevention, and letermovir is a new CMV-specific antiviral that is an option for primary CMV prophylaxis in high-risk CMV donor-positive recipient-negative kidney transplant recipients, which is a useful alternative for patients who are not able to tolerate valganciclovir. It does seem to be very effective in this population. There was a recent phase 3 trial published by Ajit Lemay and others. So the efficacy is there. One of the main issues is just that it's expensive. And then another thing to remember is that it only covers CMV. So if people want herpes prevention, they need to include a drug like acyclovir or famvir. There's also more data supporting preemptive therapy in high-risk donor-positive recipient-negative liver transplant recipients for prevention. And that was also work done by Ajit Lemay. So that's good news for people that want to try that approach. There are no precise viral load thresholds that can be used across all systems for preemptive therapy. There are a lot of issues around diagnostics, but we do say in these guidelines that perhaps a lower threshold should be used for high-risk donor-positive recipient-negative patients who are undergoing preemptive therapy, and as far as when to start treatment. So I think that guidance should be helpful for people. And then one of the things that for me has been the most helpful in the last 3 versions of the guidelines is this approach of surveillance after prophylaxis, which is when you have a high-risk situation, either donor-positive recipient-negative or higher levels of immunosuppression. And then at the end of prophylaxis, you initiate weekly monitoring for 8 to 12 weeks and pick up CMV when it happens on the earlier side rather than just stopping prophylaxis and hoping for the best. I found this to be really helpful as we detect pretty low-level viremia or DNA-emia, more correctly said, as Atul nicely explained. And that way we can initiate treatment on the earlier side before they have end organ disease. So I think that's quite helpful.
I would just add that if a preemptive strategy is being considered, and it's great that we have new data to support that, but it's just important to do it in a rigorous manner, ensuring really weekly monitoring and very close follow-up.
A good point. We talked a lot about how it's hard to do the weekly monitoring, so you need to be sure you can do weekly monitoring if you are going to do a preemptive approach.
Diagnostics is the next topic that you are covering. What's hot and new there?
So we spent a lot of time discussing diagnostics, and really in this meeting we had a greater emphasis on using quantitative NAT testing and really using a calibrated test, calibrated to the WHO standard, and preferably a commercially available lab assay. We're moving away from the older CMV antigenemia assay, although in certain settings, especially resource-limited settings, that might still be an option if QNAT is not available. We provided a lot of guidance on interpretation of very small changes in viral load, and we emphasized that we should be really looking at it on a logarithmic scale. So, for example, at very low viral loads, 2 or even 3-fold changes in viral load may still be within the give of the assay, so to speak. We again, in this section, as Camille mentioned, we discussed a lot about how to interpret low levels of viremia or DNA-emia and what treatment thresholds should be, and we couldn't really arrive at a single treatment threshold. It has to be based on the patient, the immunosuppression, and the clinical situation, as well as the assay being used, and also if it's being done in whole blood versus plasma. Camille, anything to add?
No, I think you hit all the high points. I mean, we did talk about moving more towards looking at results in log, but I think not every lab reports in log, but that is actually helpful at decreasing the noise when you look in log-based 10 results. It's basically, it shows less of a change compared to the integer numbers. So, but those are definitely the highlights.
Now, immunology is a critical aspect for CMV in general. What is new in this area, and what do the guidelines tell us?
Yeah, so we had, for the first time, I think we had an exciting recommendation that cellular mediated immunity testing for CMV, things like T-spot CMV or quantiferon CMV or other similar assays that look at cell-mediated immunity, can be useful after transplant in CMV seropositive kidney transplant recipients in order to personalize their need for prophylaxis or duration of prophylaxis. So although we've been cautiously optimistic that these cell-mediated immunity tests would be helpful, this is the first time that we've really had a robust recommendation that if you have access, you can consider using these. And I know that there are groups in Spain and elsewhere that are readily using these. Unfortunately, we have not shown that these assays are very helpful in the high-risk donor-positive, recipient-negative population. So we're basically saying that there's no suggested utility for prevention in the high-risk donor-positive, recipient-negative population. And that's been borne out across multiple different studies. So it's disappointing that where we need it the most, it's the least useful. Those are the highlights of the immunology section.
Atul, anything to add?
We also spent a fair amount of time in that section discussing CMV vaccines, as well as using T-cell therapies for CMV. So both exciting areas, but neither yet ready for prime time. But we did suggest that cellular therapies may be useful in a selected subset of patients who have very refractory CMV.
I think the immunology leads us directly into CMV treatment. The immunological treatment could be one approach and could be in addition to CMV treatment. But what overall is new and up to date in CMV treatment?
Yeah, so the guidelines continue to recommend valganciclovir or ganciclovir as really the mainstays of treatment. And there's a preference for valganciclovir for most mild to moderate cases of CMV disease, whereas you would use IV ganciclovir for more severe disease or concerns about absorption. We spent a lot of the guidelines and a lot of time discussing what the threshold is for discontinuing therapy. And the reason for this is that the new assays are very, very sensitive, and it's very easy to overtreat patients who have very low values of viral load. And we, unfortunately, in the guidelines process, couldn't arrive at a consensus threshold for discontinuing therapy, and decided it needs to be institution specific, but cautioned people to don't overtreat very low viral loads.
CMV resistance is another very relevant aspect in the CMV field. What are updates there?
Well, we thought that was one of the areas where we were making some bigger changes. We now have the opportunity to have maribavir as a principal alternative for ganciclovir, valganciclovir resistant cases of CMV. So that's a pretty pretty exciting update. We do make a recommendation that foscarnet should be used for patients that are clinically unwell with life-threatening, sight-threatening disease, or if they have higher viral loads, in that we are seeing a fair amount of resistance develop to maribavir. So there's sort of this concept of induction treatment with foscarnet, and once you have good control of disease, then perhaps switching to maribavir for some of the more challenging cases of resistant refractory CMV. We do need more data on things like combination therapy. We know that some people are using either double antiviral therapy or immunoglobulins with antiviral therapy. And so we do need a lot more information on that, and then strategies for difficult to treat cases as well. And in sort of exciting news, there's a new resistant refractory disease algorithm that was spearheaded by Sun-Wen Cho that is really helpful. And I know that's one of the most common figures that people reference in the guidelines document. It'll be the new figure 5, so that's very exciting. And we hope that that's really helpful to people. I think resistant refractory disease is one of the bigger challenges that we see when managing CMV.
Yeah, I think this is one of the area of the guidelines that is most changed from previous versions of the guidelines. So it's very exciting to have new data, new therapies.
So finally getting to pediatrics, children being a very sensitive population, what is new in treating children or in CMV in pediatrics in general?
Yes, one of the major things that was highlighted is that while there have been these large, really well done multi-center trials in the adult population, these have been lacking in the pediatric population. We really need those types of rigorous trials done to help guide CMV treatment and prevention. With that, there's 3 recommended prevention strategies. So the first is prophylaxis, the second is preemptive therapy, and the third is actually a short course of prophylaxis followed by surveillance, with again weekly viral loads being done for surveillance. And all 3 are acceptable options depending on the patient population and the risk for CMV. And then the other thing that was highlighted was that we really need more data on the use of letermovir and maribavir in pediatric patients, especially those under the age of 12.
Camille, any thoughts from your side?
No, we've made a lot of progress across all domains. There was a lot of enthusiasm, and then I know there were a lot of great conversations at the meeting and additional thoughts for research in the field and whatnot. So I think it's a ongoing, really exciting time for CMV, and we are hoping to continue to conquer the troll of transplantation as termed by Dr. Balfour way back when.
Yeah, I would add that we think this is actually the best version of the guidelines to date, and we're really excited about it, and we think it'll be really helpful to the community.
What are the big and great opportunities for CMV research moving forward?
Yeah, maybe I could start, Camille.
Mm-hmm.
There's lots of new things going on, and we discussed many of these as a group. One of the areas that I found particularly exciting is looking at treating organs prior to transplantation, and ex vivo organ perfusion is a hot topic field in transplantation, and there are strategies being looked at to treat organs on ex vivo systems to try to at least mitigate the risk of CMV by eliminating some of that latent reservoir of CMV that's found in the organs. So I thought that was a particularly exciting area of research.
Yeah, that's interesting. Camille,
if there was one thing I could have, I would love to have an effective CMV vaccine. I think that that's something that's really been lacking in the field. And, we have about a quarter of transplants in the US and Canada are the high-risk donor-positive recipient negative population. And it would be amazing if we could, provide good vaccine or at least better vaccine protection. So There's the COLT trial with the triplex vaccine that is underway in liver transplant recipients, and Moderna has a vaccine in healthy people of childbearing age. So we're sort of cautiously optimistic that those might work out. And the other area where it would be helpful to have more information would be combination therapy. And now that we actually have the opportunity to have multiple antivirals and immunoglobulins, you know, is there a perfect cocktail that would decrease the risk of resistant refractory disease or help optimize treatment of resistant refractory disease? So I think there's a lot of enthusiasm out there, and more work lays ahead.
I want to congratulate both of you again for putting this wonderful meeting up, the entire group that you brought together. This is, as you both mentioned it already, a very comprehensive document, more than 500 references, I think more references than we ever had in any publication in transplantation. The document is available as an open access document, and I highly recommend it really as the basis to an effective CMV diagnostic and treatment. Thank you.
Thank you.
Thank you.